Good afternoon, ladies and gentlemen. Welcome to a late start for the Health and Wellbeing Board on 19th of January at Derby City Council Chamber. Do we have any apologies for absence apart from Councillor Chris Poulter, Leader of the Council, who's deciding how to spend £20 million on the assembly rooms, as we've just received a levelling up fund grant for that. Councillor Whitby, Steve Bateman, David Cox and Robin Dewis. Is that the lot? Okay, thank you. Do we have any declarations of interest? None that need notifying. Okay. And item 4, which is the minutes of the meeting held on the 10th of November. Having read through them, is it your wish that I approve those minutes? Yeah, thank you, Ian. Okay, I'll accept no comment as we're accepting the minutes. And now we move on to items 5A and 5B, and these are for discussion and decision. I'll declare an interest in that housing is part of my portfolio, but I don't make any money out of it, so it's non-pecuniary. So can I hand over to Claire Mabani, Ian Fulliger to deal, and Simon Harvey and Mike Kay to take us through health impacts arising from poor housing conditions and single homelessness, adults in Derby, the health needs assessment for them. Thank you.
Thank you, Chair. The importance of health, housing and homelessness connectivity cannot be underestimated. Housing is a social determinant of health. A safe house away from potential hazards can promote well-being. However, living in unsafe or unsuitable housing can contribute to health inequalities and is proven to be a factor in many health problems. Links between cold, damp homes and respiratory disease, for example, are well documented. For those without a home, these health inequalities and many health problems are further exacerbated. The average age of death amongst homeless people in the UK in 2022 was 47 years old for a man and 43 years old for a woman. If a person's most basic physiological needs, such as shelter, are not adequately met, they are unlikely to move on to address their higher level needs and ultimate potential as a person. The World Health Organization, in their Housing and Health Guidelines, highlight that improving housing conditions can help save lives, prevent disease, increase quality of life, reduce poverty, and help mitigate climate change. Housing can play a significant role in a person's health outcomes. We are going to hear 2 housing-led presentations today. Ian Fulliger, Head of Strategic Housing in the City, will be discussing the intrinsic link between poor quality housing and health. And secondly, Simon Harvey, Speciality Registrar in Public Health, will be taking us through the findings and recommendations of a recent public health-led single homelessness needs assessment. We would then welcome the opportunity to discuss with members of the board ways in which we can continue to improve collaboration across the health, housing and homelessness agenda.
Okay, thanks. Thanks, Chair. Thanks, Claire. I'm Mike Kay. I'm from the Council's Public Protection team. I'm a head of service, and it's my team that deal with inspecting privately rented properties for housing standards issues. So I'm just going to take you through, there's two sides to the first bit of the presentation. I'm going to focus on the private rented stock condition survey that's been undertaken, and then Ian is going to come in with the bit on housing and health impact assessment. Before we move on from that first slide though, Lindsay, probably just wanted the opportunity just to acknowledge that this work has been undertaken by officers from a number of different teams. So there are officers within Ian's housing strategy teams as well as officers within my housing standards team, but we've also had colleagues from public health. And the two colleagues that are on the screen there, John Parnham and Rebecca Jones, have been central to the production of these two reports. So if we can just move on, thanks, Lindsay. I know sometimes it's difficult to see the detail on those slides, especially if you've not brought your glasses with you. So I will just try and take you through some of the information that's on these slides. This is just about the methodology that's been employed in terms of getting the information. So for those of you that don't know, the English Housing Survey do some desktop modelling on the sort of the different tenure types of residential accommodation across the country and other statistical information. And that is, as I say, just a desktop propensity modelling. It's based on private addresses. It's randomly sampled. Not a large number of properties are sampled in each area across the country, and certainly not Derby. We were lucky enough to bid in for some DLUC money, which enabled us to undertake a bit more desktop work, but then sort of focusing in on some physical surveys. And it's that information really that has highlighted some of the issues that we're going to go on to talk about. The idea of those physical surveys was to compare and supplement some of that English housing survey data. In effect, to undertake a bit of a deeper analysis. And as I say, that was the basis of the reports. Thank you, Lindsay. So this first slide then focuses on private renting in Derby. The graphic on the left-hand side there just gives an idea of the index of multiple deprivation statistics for the wards in Derby. So essentially, the redder you get, the higher the deprivation, and you'll see that they are, you know, those central wards. Link that to the bar chart on the bottom right-hand side of your of the slide, and you'll see and take from that there is a much higher percentage of private rented homes in those wards that have got a more deprivation, to the extent that, you know, that top right statistic there, 46.5% of Derby's private rented sector homes are located within 20% of the most deprived areas. The other thing then just to take from this slide is that bit of a graphic top centre, which is in effect showing the significant increase in the public rented sector in Derby between 2011 and 2021. 16.8% rising to 24.8%, 47% increase. Thanks, Lindsay. So this slide just concentrates on the number of privately rented homes that are failing to meet what we call the decent homes standard. Decent home standard is only applicable to social housing sector at the moment, although it is currently being reviewed, and the government have given a commitment to applying this standard to the private rented sector. So again, you've got that that ward graphic of the city there on the left-hand side, and essentially that's setting out those properties that bear with me, sorry. Yeah, that we've got the highest incidence of those properties that are not meeting the decent home standard. So again, the darker the blue, the more properties that we've got, the number of private rented accommodation that we've got in the wards. That actually is. So the darker the blue, the more private rented properties we've got. And then just moving on to the graphics on the right-hand side of that slide, a bit of a comparison here between the proportion of private rented homes which wouldn't meet the decent home standard. So you can see there, England 24.8% is the top figure. Derby from the English Housing Survey is 30.9%. We're actually seeing figures as high as 50% in Normanton, Abbey and Arboretum and Mackworth closely following behind. And then in the bottom right hand corner, you'll have seen there's been some media attention on these issues just recently, and that's where that 8,500 privately rented homes in Derby would fail the decent home standard comes from. And that was what's been reported. And I think in the same vein, I think they were comparing some similar conditions in Leicester and Nottingham, although I don't think they've got the level of detail that we have in Leicester and Nottingham at the moment. Thank you, Lindsay. I just wanted to spend a couple of minutes just talking to you about the way in which housing inspections are undertaken. So HHSRS is the Housing Health and Safety Rating Scheme. And for those of you who are familiar with housing and housing conditions, that's the tool that we now use that in effect replaces the old fitness standard for privately rented and also owner-occupied properties. Number of hazards that are considered at inspection, they're assessed by not just physical condition, but the occupancy of that property as well. There's 29 hazards in total, and hazards are categorised dependent on risk. So you can get what we refer to as Category 1 hazards, Category 2 hazards. The Category 1 pose the serious risk to health. And so just taking a little bit of information from that slide, because there is quite a bit on there, and I think we'll probably circulate the slides after the session so you can spend a bit of time looking into it. The bit I wanted to just pick up on there is top left, the HHSRS Category 1 hazards in the private rented sector homes in Derby. So we've got a figure there of 23.7 of private rented sector homes in Derby that have got a Category 1 hazard compared to just over 14% in England. So 65% more Category 1 hazards we found here in Derby than what is the average in England. Thank you, Lindsay. And then they do say, don't they, that a picture says 1,000 words. Maybe I should have used pictures throughout the presentation, but I just wanted to sort of go through a couple of pictures, photographic images, all been taken in Derby. Not all of them current. Issues have been dealt with. But it just gives you a bit of a flavour, really, for the kinds of things that we, are still seeing very regularly in private rented sector properties in Derby. So on the left-hand side there, you've got an image from a kiddie's bedroom Mould on the ceiling, probably due to lack of insulation in roof space, combined with, maybe not enough heat or ventilation in that room. Centre at the top, a bathroom, surface mould build up on all the surfaces. Mould was throughout the house as well, a couple of children living in that property. Centre bottom left there, typical hoarded property. You'll notice a significant accumulation, on the left-hand side of that image, just in front of the wash hand basin, the sink. Centre right, the electrical hazard. Elderly gent living alone in this property. There were other issues, clearly electrical hazards, significant fire risks. The officer was so concerned about the gentleman who lived in that property that after the inspection, they put him in their car and brought him down to our housing options team to get something sorted out with his alternative accommodation. And then finally on the right hand side, some steps, falls on stairs. That's one of the HHSRS hazards. No rail, very, very steep, particularly that stairwell that's going up top left of the screen there. There were 3 children under 5 living in that property, and that staircase there is just a serious injury waiting to happen. Thanks, Lindsay. That's me done. I'll hand over to Ian.
Thanks very much, Mike. So some quite telling images, and I know that certainly 2 or 3 of those have been taken in the last couple of months, just before Christmas, some of them. So they very much are, as Mike was saying, the conditions that we are finding in Derby right here, right now. This second part of the presentation was led by Becca Jones in Public Health. It looks at the linkages between those very poor conditions that we find in some private rented stock and their effect on people's health who live in those properties. Becca's work, this second part of the presentation, doesn't just relate to private rented accommodation, it relates to all privately owned houses. So a lot of the houses that we in this room live in as well. And therefore, the statistics that are in this second part of the presentation will be somewhat diluted to those that were in Mike's that related just to the private rented accommodation. But nevertheless, I think as we go through this second half, you'll agree with me that there's still some shocking stats that are flagged up here. So this first slide is life expectancy, females at the top, males at the bottom, and as a non-health expert, I was quite shocked when I saw this stat. I was shocked that life expectancy in the UK as a whole had stalled and was now declining. I was really shocked that life expectancy in Derby, which is the green line at the bottom of both of those charts, was falling more significantly than the national average. And we don't expect that it is purely just Derby. We suspect that there would be a similar trend for other cities the size of Derby or bigger, but nevertheless, I thought that was really concerning. Thanks, Lindsay. This one again talks about life expectancy, and it relates to the point that Mike was making earlier, really. On the left-hand side, the bar chart there, you've got life expectancy in the most deprived wards on the extreme left and rising to life expectancy in the least deprived wards. Now, as Mike was flagging, we know that the worst housing in this city is in those most deprived wards. And again, I found it quite shocking that life expectancy in those most deprived wards, where the worst housing is to be found, is around about 10 years less than life expectancy in the most affluent parts of this city. The second bar chart is a national figure. So the second one is not Derby specific, but Becca, who led this bit of work, assures me that the trend for Derby would very much follow this national pattern. But that second set of bar charts, the blue, relates to healthy life expectancy. And this relates to at what age do people fall into poor health, and poor health that is significantly bad, that it does impact into their well-being and enjoyment of life. And the trend is the same as the first chart. By far, the shortest levels of healthy life expectancy are in those most deprived areas where the worst housing is found. And you can see that in the least deprived areas where the better housing is found, healthy life expectancy is almost 20 years higher. And again, quite shocking. The red line going through there is just for reference, is the state pension age, as you can see. So you can see the majority of people, and particularly those living in the most deprived areas, the poorest housing, are leading unhealthy lifestyles many years before they get to the state pension. Thanks, Lindsay. So I'm not going to go through all of these bits on the slide. As Mike said, these slides will come out with you with the notes of the meeting, but I would just draw your attention to the two sets of bar charts on the right-hand side. And as Mike was saying, and as Claire said in the introduction, we know that cold, damp homes has a very strong link to health, and in this case it's chronic obstructive pulmonary disease. And again, it is shocking that in those areas with the worst housing, in Derwent, Arboreton, Normanton, you are 6 or 5 times more likely to have to go and have an emergency hospital admission for chronic obstructive pulmonary disease if you live in those areas than if you live in the areas with the better housing. And similarly below, it's the same story. So deaths from respiratory diseases, we know again there's strong links between poor housing, cold homes, damp and mould. And again, if you live in those worst areas that Mike was talking in his presentation, Arboretum, Abbey, Normanton, Derwent, you are far more likely to die of a respiratory disease than if you live in one of the more affluent parts of the city which has better housing. Thank you, Lindsay. So trips and falls, that bucks the trend a little in terms of where we will find trips and falls. The study revealed that trips and falls can pretty much occur anywhere across the city. There's a bit of a link between increasing risk of trips and falls and the age of the housing. But to some extent, it doesn't matter where it's occurring, it's a risk. And we know that 95% of pelvis hip fractures occur from a fall, and we know that if an elderly person has a hip fracture, there is a fairly high chance that they will not return home to independent living. They will move into some sort of institutional care. We know that people who are over the age of 85, if they suffer a hip fracture from a fall, that there is a reasonably high chance, sadly, that they will not live beyond a year after that event. Thanks, Lindsay. So I'm not going to go through all of this table, but I'll just pick out a couple of key points, and I'll just take us through it. This is an accepted model by the Building Research Establishment. It's a national body. It's a model that is accepted across the UK. And in the various columns there, on the extreme left, you've obviously got the issues. So I can tell you that you've got damp, mould growth, excessive cold, various falls under there, and then following issues below that. On the first column after that, you've got the number of those cases that our research suggests that occur in the city. The next column, you've got the cost that the study estimates it would cost us to put all of those instances right. The next column there is the cost to the NHS arising from those issues. So in other words, if we look at the top line, from damp and mould growth, we're saying there's 650 cases in the city. The cost to put that right is around about £4.8 million. The cost to the NHS dealing with those 651 cases is around £367,000. The saving, if we were able to address those issues, is £366,000. And then the final column, we've just put in a payback period. And we can see that in damp and mould growth, the payback period to address all of those 650 cases is around about 13 years. And 13 years is quite long because to address damp and mould, you're often dealing with fairly significant issues within the home. It might be stopping water ingress coming through the roof, it might be stopping damp coming up through the floor, and those are typically fairly expensive things to deal with. But if we then just drop down to the third row, it's falling on level services, and in that case, we can say the study estimates there's around 1,600 cases where there's a significant risk of a fall on a level service. The cost of putting those 1,600 places right is just over £1.2 million, and the saving to the NHS per year, so the saving to the NHS of if we were to deal with all of those 1,600 instances of a risk of a fall is 1.1 million, and I can tell you therefore that the payback period, we've rounded it to 1. It's about one year and 1 month. You'll be able to see when the slides come out to you the other instances and how long it would take to pay back those issues, but clearly there would appear to be a strong case here for the public sector as a whole to intervene in terms of putting some of those risks right and therefore delivering savings both to the NHS but then to the wider public purse as well. And the stat at the bottom right hand side there makes the point that the estimated saving to society as a whole is around about 2.5 times that greater than the figure we've quoted for the saving to the NHS. Thanks, Linton. Okay, so what next? It seems to us that clearly there's a need for strategic leadership across health, social care, housing, to see these issues as being part of one system, and certainly the solution being to much improved joint working between ourselves to come together to deliver better outcomes for our residents. And certainly at an operational level, we're beginning to have some really productive conversations about how we can certainly help with speedier and more effective hospital discharges, but there's clearly an awful lot more that we could be doing if we were working better together. As a first step of this, the Council has agreed to make £500,000 available to start addressing these issues next year, but the Council's very much looking for us to work in partnership with other public sector partners, and certainly the thinking is that if we can secure that joint work between us and other public sector partners and demonstrate some real successes in terms of dealing with these issues that will result in better outcomes to our residents, that there will be then further funding in future years. The Cabinet and the Council has agreed to consult upon the introduction of selective licensing or additional licensing. That will help address, if we do go down that route, some of the issues that Mike was referring to within private rented accommodation, but clearly in itself that is not the answer here. And finally there, we just wanted to flag that the government is thinking along very similar lines. And the white paper, as Mike was saying, proposes a decent home standard could be introduced across the private rented sector. But we very much feel that on the back of the research that has been done, we need to be taking action now and not waiting for something that may be introduced by the government at some point in the future. And we're going to move on to Simon's presentation in a moment, but certainly after that, we'd really love to start a conversation with this group as to really the first point. How could we, as a group of leaders across various different public sector bodies, start to think to work together better to try and address some of these issues? Thank you, Chair.
Do you want at this point to go into initial questions, Ian, so that while it's fresh in people's minds that we get some of these issues looked at? I know I have responsibility for this, and it's been important this survey has taken place, and the results of it are quite shocking. But I've got to say that we have some extremely good private landlords across the city, and they work well with the services that we provide, the Healthy Housing Hub, the Decent and Safe Homes team. So we have got work going on across the city to address some of the issues with private landlords and in the private sector housing, and we've done quite well out of grants from government over the last few years. But it's those that don't comply that we're looking to target, and I do mean target for advice and help and assistance where we can. But if they are not prepared to engage, then we would look at going down the enforcement route. So I'm taking this seriously. I just wondered whether there was anybody in here who's literally concerned about health impacts and whether there's something we should discuss at this point. I'm looking at the fire service, yes.
I've got our quarterly and annual performance statistics up at the moment, and if I'm quite honest, the linkage between it is shocking. If I'm quite honest with you, so in rolling 12 months, we had 390 accidental dwelling fires. Now, to those 390, almost exactly half were within South area, which is Derby, South Derbyshire. And out of those, almost without exception, it's within Kingsway and Asker Drive station areas, which is Arboretum, Derwent, and Normanton wards. Again, we can't be scientific about it at the moment, obviously, but I think the linkage is quite stark, particularly with the fire hazard as well. I've got some general question. I'm not sure if you could answer, but when something is spotted as a fire hazard, what's the linkage back into us? And also, this is what we've been. Again, there was the television news article the day this Councillor Webb was leading. I was looking at interest with that about the St James's Centre and so on. This is what we've wanted for the last few years, because this is traditionally the difficult areas for us to get into. Just to sort of compound it, our mosaic status of our accidental dwelling fires, the three highest mosaic references are single people in low-cost homes, families with limited resources, and urban residents renting high-density housing. So they're by quite a way our three most highly populated instances of accidental fire, which everything I've just said, I think, links almost scarily into everything we've just heard. So the final thing is anything we can do to be involved or help fund, please let us know, because this is a direct link into our issues at the moment.
Thank you. Anybody else? Chris?
Thank you, Chair. And firstly, I'm just really pleased to see this at Health and Wellbeing Board. It feels like the place to discuss this, and certainly the approach we're taking on the wider terms of health, social determinants, that this feels the sort of coordinating board to be looking at it. So that's thing one. Thing two would be, taking this forward, it'd be really helpful to see some wider information on how Derby does compare. Because it seems on the surface that we've got a particular problem in Derby. So I think we'd want to see further information around other areas, what information we have, and understand, is this a general city issue that's comparable, or is this a specific Derby challenge that we've got? And that's thing two. Thing three would be just to flag that whilst in principle, yes, if we manage these things, there would be a saving in terms of the NHS, because, you know, people with respiratory issues, if we manage the dam, wouldn't have them. That doesn't mean we would be able to take the money out, because it doesn't, as we know, there are other things that would take their place. So we just need to flag that. Let's not make a like for like, link there, but let's have that conversation about how we would support. And then I suppose it leads itself to further conversation, doesn't it, about, well, how would we work together on it? Because clearly the health service has got a vested interest in being involved in this conversation. So thank you, Chair.
Thank you, Chris. With regard to working together, I think there might be a recommendation from our housing colleagues later on about how we go about doing that. Is it Rachel and then Andy?
Yeah, thanks. And I've heard the presentation before, and it never fails to upset me, I suppose, really. But I wanted to make a more strategic point about what's been happening, if you like, in the housing market over the last 20 to 30 years. Because we used to see poor conditions in housing, in social housing. There was a real focus then of government on really creating a decent home standard, creating a regulatory structures around social landlords, and really dealing with that stock really effectively. But what we've seen over that period is a complete change in where affordable housing is sitting. The lack of capacity in affordable housing in the social sector, because the restriction of the supply of those houses, and therefore we won't be able to get them. They're prizes to be won now to get a council house. It means that the private rented has grown, and that percentage increase of our population, and often our young family population living in private rented accommodation, has become as a national issue, because also the other side of that is the inaffordability of buying a house for yourself. So there's a real large proportion of our population who are living in this accommodation, and it is largely unregulated. There is not a regulatory regime around this sector. I'm sure members of the board are quite aware that there's been discussion recently by government of getting rid of what's called the no-fault eviction, which effectively means there is no reason, you have to give no reason as a landlord to evict a tenant after their 6 months assured short-hold tenancy. They have no security of tenure, and after that 6 months, they can be just got rid of without any reason. And what that means is that the reality of a family living in accommodation, raising an issue about mould or repairs in their property, have always got that risk of being evicted from that home. And we see through the homeless route, as we'll sure talk about later, the number of properties of people who come through homelessness who come from that route, who lose their assured short-hold tenancy and end up in homelessness. The whole system around our housing market is really, it is broken. It doesn't work. But what it does mean is, and because of the lack of regulation, there are landlords who are, able to make quite decent amounts of money on quite poor conditions. And Roy is right. We have some really good landlords, and that's great. And we're bringing in some additional national sort of bigger players into the city with the Beckettwell development, etc., who will up the ante, I think. But in parts of our cities, and it is all cities, I think, to be fair, in urban areas, Chris, we have got a propensity of poor quality landlords, perhaps with one or two properties, with no real sense of what they need to do. There's no regulatory framework to stop them doing things, and the condition of properties is really, really poor. And we're seeing that horrific reduction in life expectancy on the basis of it, and it's really appalling. But the tools we have to tackle it are the regulatory regime being quite weak, but also the capacity of what we do have, which is the environmental health, the health and safety housing rating that Mike talked about, is a tiny team inside a council, and there used to be a lot of funding from government, capital funding, to do work in the private rented sector. That dried up about 12 years ago. There was very little around. So we're seeing the problem getting worse and some of our tools being less able or less capable. So it makes it even more important that we work as a system and see this as a system problem. And it's not easy because taking money out is really hard, isn't it? Because there are other things that are really important as well. But if we can work collectively to find solutions, that's the only way we're going to be able to tackle some of it. Thanks, Ryan.
Thanks, Rachel. Andy, and then I'll move on to the next part and hold your thoughts, Paul.
Thanks, Chair. To some extent, Chris and Rachel have covered the points I wanted to make. I'm interested in the insight and the data, and clearly what's been presented today is hugely sobering and, you know, massively shocking, given, you know, the society that we live in and the fact that we're in the 21st century. And I'd be interested in what our kind of forward insight looks like in terms of where do we think we're going to be in the next, you know, 18, 24, 36 months, because, you know, that might be quite difficult, but I suspect it's going to get worse given where we are and given the wider societal pressures that communities and families are experiencing around cost of living, around energy prices, around the lack of regulation that Rachel's referred to, you know, the ever-increasing challenges that local authorities have got to get into this space because of pressures around finances, etc., etc. So that dip in life expectancy that we've seen nationally and in Derby, where we've seen a sharper dip, you know, is, well, it's probably going to get worse before it starts to level off and hopefully go back up. But it'd be useful to get some insight into that, because that might then inform what that strategic, you know, medium to long-term planning needs to look like. I don't want to steal your thunder, Claire, for later, but I'm really interested in, you know, what strategic recommendations might be coming to the Health Wellbeing Board around how do we work as a system going forward in this space, and what are the opportunities, and how do we use what works well in this space, because we have got examples of services across the system. We use our Better Care Fund creatively, for example, around Healthy Housing Hub. We can see a real direct link between those services and reduction in falls, reduction in people going into hospital and so on. So it's how do we use that insight and that analysis collectively to try and work on what we think, you know, will make a difference, whilst also thinking creatively as we can, notwithstanding Chris's point around, you know, resources, and this is a complex system, but, you know, there may well be different ways in which we can use our resources going forward, because this also takes you into a much more preventative conversation as well, doesn't it, in that medium to long term, you know, and all too often we're very reactive, aren't we, as a system, because, you know, of pressures, targets, because of the here and now, but how do we really try and sit back and take that long-term, medium to long-term strategic preventative view in this space, because that's ultimately what we're talking about here. Thanks, Chair.
Thanks, Andy. We'll now move on to Simon's part of the presentation about single homelessness in adults, and then I'll take a general round of questions afterwards. So I've not forgotten you.
Right, the first thing is to make sure the technology works. So despite being a specialty registrar in public health, those who know me will know I'm not a specialty registrar in IT. So just as a bit of background, I started my training in public health at Derby City Council. I was here for a couple of years. I started this piece of work at Derby City Council thinking that I'd move on to NHS England and leave it all behind, and it's followed me. And here I am again, back where I sat today where I was 2 years ago, the other side of the COVID pandemic. So I guess the first thing to ask is the question about why this needs assessment, why single homeless adults. And I think the first thing I would say is, in terms of homelessness, if we were talking about inequalities between the most and least deprived in the last presentation, when you come onto the difference between those who are homeless and the general population, that 10-year gap you multiply by 3 or 4, it's stark and it's bleak. And while it isn't quite clear unless you've got better eyes than I have, the pie charts on the right, the same leading killers for the general population are also leading killers for people who are homeless, but with added causes of death relating to substance and alcohol misuse and dependency, and mental health and suicide. And if we were talking, this is life expectancy, not healthy life expectancy. So again, you can imagine maybe what healthy life expectancy would be like for this population. So we move on to the next slide. I don't have as many graphs as the last one, so it's going to be a lot more of me talking, I'm afraid. So we narrowed down this population for single homeless adults. One of the other reasons for homing in on this population is because if you're single and you're homeless, unless there is some other major reason why you should be a priority for having support to get accommodation from the local authority, you're not entitled, you're not eligible for that automatic provision of accommodation by the local authority. So the situation is a lot more uncertain. This is the population who is represented in kind of the sharpest end of homelessness, in the rough sleeping, in the night shelters. And this is where we were expecting to see the worst health. So it was an opportunity to try and understand this population and understand it for this population in Derby specifically, not just in general terms, and then the opportunities to make improvements for the health of this population. If we can move on to the next slide. So again, this turned out to be, so we've tried to sort of take the standard, a sort of a fairly standard methodology. So we'd scoped out a population, done a review of the literature, look at national sources of data on this population, local sources as well, interview people who understood this population, mindful at the time this was in the middle of the COVID-19 pandemic when a lot of the face-to-face interaction was just not possible. And then to try and measure what's going on in terms of support for people in Derby against some kind of benchmark standard. And the benchmark standard appeared halfway through the needs assessment, which is the NICE guidance, NG214. And then what I'm doing today, I guess, is summarising everything that, as much as I can, that I've pulled together. So this is the short version of a much longer report. The long report's about 150 pages when it's issued. I'm not going to subject you to 150 PowerPoint slides today. What I would say is that this was a much harder task than I expected it to be in terms of specifically getting information on not so much homelessness in general, but homelessness in Derby and particularly the health of people who are homeless in Derby. But I think what we've managed to pull together for you when you see the full report as well is a pretty rounded picture of physical health, mental health, substance and alcohol misuse, long-term conditions, comorbidities, and social care as well. Move on to the next slide. As I say, I haven't got graphs, but there's some of the headline statistics in terms of the health of the population who were homeless in Derby. So in terms of the number of homeless single adults within statutory housing data, I'd identified in 2021 that there were 825 single homeless adults. That's among all the households. Obviously, the number of households who were applying for support for homelessness was larger than that. And also what we got within that as well, and this is perhaps, there are not many things to thank the COVID pandemic for, but one of the things for this population is we were able to get a more accurate number for people who were on the edge of rough sleeping due to the everyone in policy that came in with lockdown. And that number of 150, which was from the everyone in count, also was validated through a trawl of adult social care records. Somebody pulled off an extract of data from Liquid Logic, and we were able to look at the numbers of people who were identified as adults who were single homeless, and it came out with a similar figure. it was a younger population than the general population and predominantly male, more predominantly male as you got nearer to the edge of rough sleeping. Worth noting that some of that, the fact that it was a younger population, is because the older population is very underrepresented within this population, which comes back to that gap in life expectancy between the homeless population, particularly rough sleepers, and the general population. What was also interesting, and it was because we were able to look at, so one of the things we were able to look at in terms of housing and health through the housing data set was you could actually compare health needs based on acuity of housing needs. So essentially, for those who know the housing framework, they'll know there's a prevention duty and then there's a relief duty. Prevention duty for people who are at risk of being homeless, relief duty for people who are now homeless. And one of the things you could see within that was that actually the acuity of need increased as the acuity of health need increased on a sliding scale as the acuity of housing need increased, with the worst health being those who were rough sleeping or on the edge of rough sleeping. They were also much more likely to have multiple and complex health and care needs, to have multimorbidity and long-term conditions. And what was interesting in this is actually some of that poor health actually starts not just at the point where someone is rough sleeping, but actually you could see that through the whole cohort of people who were asking for support for housing, who were single adults, and that complexity of needs increased as the acuity of housing need increased. In terms of, again, perhaps not unexpectedly, a high proportion of people who had concurrent substance or alcohol dependency and mental ill health. And also, perhaps pulling out from the qualitative data from housing providers of increasing concern about what I would call young old age pensioners, people who are in their late 40s or early 50s who basically have frailty levels of what you'd expect to see in someone in their 70s or 80s. And really uncertainty as to what to do with that population. Even from the housing data, there's a lot of stuff in there around the high proportion of adults who are now homeless, having been in care as children, and in some of the population cohort studies that have followed people through the life course, those adverse childhood experiences of abuse and neglect are then predictors of an increased risk of homelessness in adulthood. And women, again, one of the other things we looked at was the difference between women and men in terms of the experience of homelessness. So among women who were homeless, significantly higher proportion experienced domestic and sexual violence. And when you looked at the number of sort of concurrent needs and the complexity of those needs, that was also higher among women who were homeless, even though the overall proportion of women who were homeless was smaller than men. And finally, which is thanks perhaps to the other, say coming back to the one of the benefits of lockdown and the pandemic, was that again, in addition to identifying those 150 people on the edge of rough sleeping, what we were able to do was drill down actually to a smaller number than that, who were extremely complex, who are in and out of accommodation, and who it has been very difficult in the past to sort of stabilise and support. But again, the pandemic has enabled us to drill down to those numbers. So the next slide, please. So I guess one of the things as well, which is thinking about this population as a population, is this isn't the only population where there is a 30-year gap in life expectancy with the general population. And it's also not the only population who are extremely complex in terms of their needs and challenging to support through mainstream services. So you could add in other populations of people who were entrenched opioid dependency, or adults with severe mental illness. And similar to those groups, this is a population who does require a more specialist and personalised approach to care. And it may be something to think about them as a wider population. There's also something about, in terms of, when I was discussing with, again, I had a series of conversations with providers, service providers across a range of clinical specialties. There was no shortage, I think, of clinical expertise in terms of what to do with specific conditions. What I think was challenging was not so much whether there was clinical expertise in the system, but actually what the right approach was to providing support to this population in order to help improve their health. Within Derby, for those who know, who've had experience with this population, will have come across a paramedic service in Derby, a lady called Tracy Cunningham, who provided a really critical role for this group, and very often sort of the go-to between services, as a person who was a sort of a trusted personal relationship with people experiencing homelessness, but who also had good knowledge of how to navigate health services, and who very often acted as a single point of contact when people had got concerns about health relating to this population. I guess one of the things is we're actually sitting on a lot of this data. So again, one of the key findings for me was when I finally found the data, it was data that we were sitting on. Actually, we've had this data all along. What we perhaps haven't done is sort of drilled into it and used it in a way that can help support the health of this population. To give you an idea of what I'm talking about here, so this is a population who are their use of healthcare services is quite different to the general population. Very often it can be quite sporadic, inconsistent. When they do engage with health services, it can be very often be when they finally go into hospital because they've got no choice, and the outcomes can be quite poor. So if you had to characterise the health of people who are experiencing homelessness just from, say, NHS service activity data, it would be quite hard to do. Whereas the housing data, as everybody who approached housing services was being asked about their health, and there would be data collected on mental health, on drug and alcohol dependency, on some of the background issues around repeat homelessness, history of offending, being in care, learning disabilities. A lot of stuff that we were gathering routinely, which age, sex, which actually is really important for characterising the health of this population. And again, it's just, making use of that. And I guess the last thing, which is a challenge, and I think this is something that I didn't find much evidence of, but it is something in other areas which I think is something to learn from, and that is actually within this kind of specialist personalised service, it's really important to include the voice of people who have the experience of homelessness in developing those services and identifying the gaps. So to capture the voice of people who are experiencing homelessness against all the restrictions of the pandemic, I was supported by Healthwatch Derby, who went out and developed a survey. So we were able to capture some of that feedback on people's experiences and people's experience of health and care services. So the next slide, please. So I'm going to whiz through these ones. It may seem a lot of slides. I'm going to talk less about these, but essentially this is thinking about what recommendations, and I caveat this with, it's not my decision what you do as a system. The decision ultimately is yours following discussion about what you think the best course of action is. But I think the first recommendation I'd make for all sectors is, we've kind of highlighted the needs in this needs assessment, the full version of which will be circulated. This population isn't going to advocate for itself, and it's really important for the role of health and care services and housing services to highlight the health inequalities that exist and to advocate for meeting their needs. The second one is actually, previously when I started this, there wasn't really a benchmark. There now is quite a detailed NICE guidelines which have developed, which include recommendations for housing, health and social care providers in meeting the health needs of this population. In the full document, when it's circulated, I have done some mapping of that against what I've found in going on in Derby, but really I would refer people to look at that document in depth for their own particular sector. The next one is about thinking about the connections between services. That actually, if someone turns up at your service who's homeless, but your service isn't housing, then really there should be referral pathways. There is a process under the law, the duty to refer to housing support, which applies to certain agencies. But even if you're not one of those agencies, again, if you're regularly seeing people who are experiencing homelessness or even intermittently, again, it's developing those referral pathways so that I'm thinking about a no wrong door approach. I've mentioned already the duty to refer, and then thinking about this population needing a more personalised approach, a more specialised approach. Again, it's thinking about how you build in flexibility into service access. Some of the challenges around using mainstream services are that they don't cater well, or they're reported not to cater well for people whose lives don't work according to a very rigid timetable. And again, it's how you build in flexibility to accommodate this population so that they're not facing barriers to care. Next slide. Next one. Okay, data sharing was mentioned as a challenge. Again, with this population, a lot of agencies are seeing the same people. There are challenges in how data on the same people for agencies who've got the same concerns can be shared. And it's an area, again, to look at how you can improve that. I've mentioned about the role of experts by experience. Again, thinking how you take advantage of that within Derby to design and evaluate health and care services. There was an issue around different workforces, their actual understanding of homelessness, and there is a workforce development issue for services who are not housing about how to get this kind of training so that people do have more of an understanding of the challenges this population faces and the avenues that are available to supporting them. And I've added in about a trauma-informed approach, because one of the challenges is that trauma came across from the evidence as being a major issue in the lives of people experiencing homelessness, whether that was trauma prior to in earlier life or trauma experienced through homelessness. And sometimes people being asked to repeat their life story each time they face services and just reliving the trauma. So again, it's that developing that trauma-informed approach. There's one of the things that came out in the NICE guidance was around the issues of actually thinking about rights of people to access healthcare. So again, it's what information people can be given to actually empower them to get the right, not just opening the doors to services, but empowering people to know where they go for support. And mindful that a lot of health and care services are very time pressed and healthcare appointments can be very short. This is a population who need more time than mainstream services are often prepared to give. So again, it's thinking about how you build that consideration into service for this sector, for this population. Next slide, please. So now we're getting on to the more sector specific. So the first thing I'd say with housing is that if I learned anything from this needs assessment, it is that housing is very much the front door to health for people who are homeless. essentially, if you don't have a house or your housing situation is extremely unstable, it goes along that your health is probably also extremely poor. But also the fact that when people do approach housing services, a lot of work is done to signpost people into things like GP services, dental services, substance misuse services. There's a lot of opportunity to signpost people at that point that they approach for support to get the support they need, and also to capture data on their needs.
I'm sorry, Simon.
I've run out of time, have I?
Yeah, we've reached a point
Yeah, no
where
problem.
you've made a considerable number of recommendations, and I sympathise with exactly what you're trying to do. And looking at the homelessness situation that we've got in Derby, you're pointing out that it's not just those that we see on the street that have reduced considerably in the last 5 years. We've gone down from 37 down to single figures of street homeless, but it's those complex lives. And I do know that there is a group that are looking at specifically those people with complex lives. What I'd like to do is to make a recommendation that this goes to our housing subgroup, and that group comes back to the board with some recommendations as to what we need to do to take things further. Because we've done a lot, we've worked with landlords, we've worked with health colleagues, and you mentioned Tracy from EMAS, but you've also got mental health support. So we've got buy-ins from colleagues in health, and since this report has been put together, there's been also a Just Giving service whereby instead of giving to people on the streets, that people can donate by using a QR code to make those donations, so we are not supporting people to fund drug and alcohol habits. So thank you very much for that presentation, but I do need to wind it up and open it, and I know Paul had got a question that was relating to the earlier issue.
Yeah, thanks, Chair. It's just three very quick things. I think on the presentation around the housing, when we talked about, we talked about the cost impact of the private housing. Obviously it talked about the actual issue, and it talked about the NHS, the impact on the NHS. I think it'd be really interesting to take that forward and actually the extra knock-on effects it has cost-wise. So, for instance, people that are in private rented, bad things that access free food and access other resources in the voluntary sector, that is a very time-consuming thing. I think it'd be good to expand it so we have a bigger picture of the actual cost impact, not just around that. I think from a Poverty Commission point of view, I think obviously we highlighted there was 50% in Normanton, and I think a very real issue that we see is people are scared to speak up because they're at risk of losing their properties. And I think, if we actually got more of the voice of people that were impacted, I think actually maybe some of the issues might be a bit higher than we actually think. And I think it's important that we take into consideration the fear factor and the voice of the vulnerable people within that. And I think my third thing was that I think this isn't a new issue for us to discuss as a city around private rented houses. And I remember probably 8 years ago, we were kind of talking about this. And I think Rachel's point about, a collaborative response is really important, because I think, whether it's the Poverty Commission or other voluntary sector organisations and people coming together to not just physically look at the house situation, but all the impact around it, I think is really important for us to do.
Thank you. Just on the back of what Paul said, insight that we have, from a Derby Health Inequalities Partnership, is that the there's not enough people coming forward with the concerns, because there's an element of normalisation within communities. Because some of the housing that we see, it's quite generational. People that live in there, the landlords, right when from some of our migrant communities came in the 50s and 60s, it's always been like that. And then you tie in literacy, be it reading, writing, and digital literacy. You know that the problem in terms of addressing it, or for tenants to actually raise it, becomes more difficult. And I feel that the VCSE sector plays a massive role within this. And we're probably at the right point, because when it comes to addressing health inequalities, so the Core 20+5 program, one of the 5 key areas is chronic respiratory disease. And we've actually just rolled out a program where we've got community connectors, people at a grassroots level that are going out and addressing this and becoming champions. So we can really utilize and build upon this, because the first step is to raise awareness within communities at a community level, and the community is best to do this. Naturally, what that will do, that will put pressure on landlords, because once they know that tenants are aware of their rights, then hopefully you can start to see some sort of accountability and things getting a bit better.
I can understand the point that you're making about tenants' rights, but whilst Section 21 notices no fault evictions are out there, then tenants may have the rights, but they also have the fear of losing their home if they upset their landlord. Okay, are there any other? Yes, Claire.
Thank you, Chair. Just in terms of pulling this discussion together, there were 2 specifics that we wanted to recommend the board to consider. The first was to ask for some strategic support and prioritisation to attend the subgroup of the Health and Wellbeing Board in relation to housing, health and homelessness. That is the multi-agency board that's been set up to be able to consider some of the things that we've discussed. And we are really struggling at the moment in terms of attendance across all sectors. We do have strong attendance from social care, public health, and obviously housing. But we have struggled to be able to land sufficient attendance at that group. So any strategic support and prioritisation to attend would be fantastic. And also maybe a sense check as to whether we've got the right people invited, from because it may be that we haven't got the right people invited. Very difficult for housing to navigate across health services and know that we're in the right place, talking to the right people at the right level. And the second recommendation was around where that subgroup of the Health and Wellbeing Board might also pack a punch in terms of being able to report perhaps jointly into the Integrated Care Partnership, and whether that would help strengthen attendance, but also help embed the health, housing and homelessness discussion, and whether that could then, the health, housing and homelessness group could then be that pivotal group to look at things like the NICE guidance, and have an action plan that we could actually collectively and collaboratively own. So I guess those were the 2 recommendations that we wanted to bring forward for consideration.
Thank you, yes. Just to clarify, would you be looking at asking the Integrated Care Partnership to join with the Health and Wellbeing Housing Group to make a targeted group across both organisations?
Chair, I think we'd be looking for guidance in terms of which was the best route. I think what we have recognised is that in order to get an equal playing form and platform around recognising the value of health, housing and homelessness in one multi-agency forum, that we need to report through to the Health and Wellbeing Board, but we also need a more direct route into health and social care.
Chris?
Yes, I don't think we'll solve it in this committee, I genuinely, but I think there's a commitment. I'm just going to look at Andy about whether we could look at this, Andy, in the ICS Executive Forum. What I wouldn't want to do is move the ownership of this agenda from the Health and Wellbeing Board. The Integrated Care Partnership is doing a different role between the NHS Public Health and Social Care. And I think we've got to empower this group and have an approach that takes it forward. So I'm just wondering, Andy, could we put it there to consider? We've got the right colleagues. If that sounds all right.
That sounds very pragmatic, and we've got an exec next Friday, haven't we, Chris? We can pick it up there.
Okay, that seems to be a solution. Would there be any objections to that being carried out? Okay. Yes, Alison.
Thank you. I just want to ask a fairly factual question, really. I'm just wondering, because often we see these statistics about the shocking contrast between the life expectancy of those who are housed and those who are homeless. But with respect to the figure for people who are homeless, I mean, presumably that's the age at the point that they are when, the sort of average age they are when they actually die. But of course, they won't have spent their whole lives homeless. I mean, I very much doubt anybody spends their hope nobody spends their whole life homeless in our society. But so what my sort of question is, it's like, how is that figure arrived at? I mean, just a brief response. If you, I know you said it's very difficult to get information on all this, but because I do want to kind of quote that figure. I do want to use that figure because in terms of promoting this as a problem and something that I'm sure most people will be concerned about this. But I mean, does that include people who say been homeless for just 5 years, or they're homeless for a year and they die at 45 and they're in that figure? Do you see what I mean? How do you assess that? How do you get to that figure? Thank you.
Over to you, Simon. You're the statistician.
Right, okay, well, I'll do my best. So the data on the average cause of the average age of death is taken from mortality data. So it is at the point where someone dies and they're recorded as homeless. And I don't think it's more complicated than that, for that data. What was more interesting, though, is there was another study which looked at housing tenure and life expectancy. So actually, we see, like, for the most deprived communities, the life expectancy is lower. And if you just went off homelessness statistics, you just think, and then they fall off the cliff and they die. But actually, as you get, there's sort of other steps in things like insecure, like sofa surfing, of bed and breakfast accommodation, and other kinds of unstable accommodation which get increasingly worse. And life expectancy does get worse as you go sort of through worse and worse housing tenure. So I think, yeah, that figure perhaps is particularly true for those who are of sleep-in, but what it's worth bearing in mind is the lack of secure housing really isn't good for your health, and your life expectancy and health is likely to get worse as your housing situation gets worse. So it's making sure, I suppose, you don't separate the two.
Thank you, Simon. Yes, Sue.
Just a comment, if anybody wants to look at the Health Watch report on homelessness, it's available on the website, Derby Health Watch.
Yes, and it's a really good report, thank you. Rachel.
That's right. I was just make one sort of point, really, and it's a plea, and I think I've played quite a lot in different places, but there is something about the way we as public organisations, public services, look at problems, because we have to, because of our organisational priorities and our systems we work within, but it's often quite unhelpful. And one of the things about particularly rough sleepers and them being homeless, and we call them homeless, a homeless population, the homeless bit is almost the last part of their problem, really. Everything else in their life, the trauma, the impact, adverse experiences, the domestic abuse, the addiction to substances, the trauma, all those things are actually as important, but we label it and put them into a homeless place, and we say, oh, the housing team could fix that problem. And I'm not suggesting that's what we're doing here at all, but there's a real danger of us thinking that our different bits of the system are somewhat separate, and therefore we don't always, think of it from the person's point of view. And, being a housing officer for a long time, a lot of my career has been trying to argue that it isn't really about housing, it's about the problem with that person. And so I really said we can really put that energy into how we empower some of our teams to really think much more about the person and the outcome as opposed to the organisational perspective. That will help us to make a more collaborative outcome.
And I totally agree with you that we've got to look at this holistically. Claire and I had been tasked by the Secretary of State to actually target 5 most difficult cases for homelessness, and we've been through that review. Unfortunately, 2 of the cohort actually passed away during that exercise, but it does reflect specifically around the issues that you've raised prior to them being street homeless, because it's a downward spiral that people don't seem to meet the criteria for individual services, but collectively, if we got together and looked at that person holistically, we could all offer parts of our service that would help resolve the situation. So the recommendations that have been made to actually give it to our housing group or housing subgroup, and for the ICS executive to take this on board with regard to getting better membership at that subgroup, then I'm hoping that that is going to be literally a giant leap forwards. So thank you very much. Anybody disagree with that action? In that case, that will be done. Thank you. Okay, now I move on to the items for information, and this is where Alison stars. So over to you, Alison.
Oh dear, I feel the big build-up, and I may let you down on the stardom element. But yeah, as Chair has mentioned, these are items for information, and the first one relates to recent guidance published in relation to the Health and Wellbeing Board. So the Department of Health and Social Care published in November of last year final guidance for health and wellbeing boards. I think I'd previously brought to the board information on draft guidance, and the final guidance hasn't changed significantly from that draft guidance, but a few points just to bring to the attention of the board. So to note, as kind of referenced in 4.2, the guidance published is non-statutory, and it sets out the roles and duties of health and wellbeing boards and clarifies their purpose within the new health and care system, and particularly that, as we've discussed here before, the establishment of the integrated care boards and integrated care partnerships. So further to note is that health and wellbeing boards will continue to have their statutory role in relation to carrying out the functions in relation to delivering joint strategic needs assessments and the now joint local health and wellbeing strategies. So that responsibility remains there. The Health and Wellbeing Boards will remain a formal statutory committee of the local authority, and the statutory membership also remains the same. Health and Wellbeing Boards, so in terms of role and expectation, they're still expected to continue to lead action at place to improve people's lives, and obviously to work in partnership with the Integrated Care Board and Integrated Care Partnership, and on those lines there's expectations of all those partners in terms of how we work and kind of the relationships that develop there that's set out in 4.8. The paper just again goes on and kind of, I think, picks out some of the relationships between health and wellbeing boards and integrated care. Health and Wellbeing Boards and the Integrated Care Board, particularly in relation to the joint forward plan, which I think the Integrated Care Board received guidance on just before Christmas, and the role of the Health and Wellbeing Board in the development of that. And similarly, within the role of the Health and Wellbeing Board in relation to the integrated care partnership. And just to note, I suppose, development on that from previous health and wellbeing boards where we've kind of talked about the development of the integrated care partnership as a formal statutory joint committee between both Derby and Derbyshire councils and the integrated care board, and that has now been kind of formally approved by all the relevant bodies, and the first formal meeting of the integrated care partnership as a statutory joint committee will take place next month. And also, just finally to note is around the development of the integrated care strategy, which is the responsibility of the integrated care partnership, which is in development, and the role of the Health and Wellbeing Board in supporting the development of that, but also reviewing its own health and wellbeing strategy in light of the integrated care strategy, which I'll come on to a little bit more in the next paper. But that's, I think, all I wanted to bring to the attention of the board for that item, Chair.
Okay, any questions? In that case, move on swiftly, Alison.
Thank you. So this is an update from Joined Up Care Derbyshire, but particularly in relation to the Integrated Care Partnership and Integrated Care Strategy. And I know there's kind of members on this board that are also members of the Integrated Care Partnership, so may well have further information to add. But I'll just kind of jump on to page 2. I think the first points of information, I think the Health and Wellbeing Board is already fully aware of, and I've kind of already mentioned that the Integrated Care Partnership has now been formally established. So primarily to note the development of the Integrated Care Strategy and kind of a development of the framework that was referenced in the last board has now been developed, and I think is attached to this document, and sets out kind of 4 strategic aims of the integrated care strategy, which is set out in 4.7, and also the focus and the need to do things differently and kind of work in partnership, and trying to work out where really the added value of working at that integrated care partnership across Derbyshire level will have the most impact. Kind of 4.8 lists out, I think, key focuses of the Integrated Care Partnership in relation to working with the Health and Wellbeing Board that developed through the previous development work. So next steps within the Integrated Care Strategy are set out in 4.10, but essentially the kind of next phase of the development is kind of fully underway, with a draft of the Integrated Care Strategy going to the upcoming Integrated Care Partnership at the beginning of, or early in February, with a view of having a final Integrated Care Strategy in April. And as I said previously, the Health and Wellbeing Board will then be reviewing its Health and Wellbeing Strategy in line with those. And again, I don't think there's anything further I wanted to add there, Chair.
Thank you. Any questions? In that case, Kirsty, you've arrived just in time. It's Better Care Fund.
Hiya, sorry about that, Chair. Just getting used to the technology. Yeah, I'm Kirsty McMillan, Director of Integration at the City Council. I'm going to do a very short report on the Better Care Fund. I was actually here at the meeting in November where we were approving the Better Care Fund for the full year, but since then we've had receipt and confirmation of some additional monies that the Department of Health and Social Care is making available to local areas to do with supporting hospital discharges. Most people may have heard some of it in the national press because it was very well trailed. And what we need the board to do today is to note this additional funding and how we're proposing to spend it in line with the grant conditions. So like I said, I came back to the board just before Christmas on the full plan. But a couple of months before that, the government had announced that they were going to provide £500 million to support timely and safe discharges from hospital. but we didn't really have the details at that point, and we weren't aware that it was going to be pooled into the Better Care Fund. So that's all become news to us since then, really. And we've only just had the final version of the guidance a couple of weeks ago. So this is fairly hot off the press. The report just gives you a bit of the policy framework behind it and how the money's being allocated, but it's essentially split between the Integrated Care Board and local authorities. And obviously we have 2 health and wellbeing boards and 2 local authorities in the Derbyshire ICS. So under 4.8 of the report, there's the amounts that have actually been allocated. They have to be spent by the end of the financial year. So it is quite challenging to try and make sure that that money is not returned to Department of Health and Social Care. So we've decided, and Appendix 1 sets that out for you, that by and large, most of the activity is supporting the planned activity that we would put in place for winter as far as it relates to hospital discharge. So it's not everything we're doing for winter between health and social care, but it's certainly the elements that relate to discharge. So there'll be an equivalent appendix like this for Derbyshire. I've obviously just provided the Derby City version of this, but the element of the funding that goes to the NHS is pooled across both local authority health and wellbeing boards. So actually the areas of activity that are on the health side are broadly the same for Derbyshire, and we've just apportioned the cost to the different elements of the funds. So if you look at the appendix, particularly I'd look at page 6, 7 and 8, that lists what we are currently proposing to spend the total fund for Derby City on. I say that that's what the current proposal is. Obviously some of it relies passing this on to particularly private sector care organisations who are not necessarily geared up to assist us. So we're monitoring this on a fortnightly basis. So the spend allocation may change, but it's in these broad areas. So you'll just have to, and I think there is an acceptance that actually if we do need to change how the money is spent, we've got the flexibility to do that. But certainly thought it was good to bring the addendum to the Better Care Fund here, particularly because you've very recently signed off the plan, and just to let you see how we're trying to work together between the NHS and local authorities to ease the pressures, particularly on the NHS over the winter period. So that's all I was going to say, Chair, if anyone wants to ask me any specifics.
Thank you, Kirsty. It's nice to note that at item 12, the voluntary and community sector are getting a proportion of the fund to support those discharges. So good to have them involved. Any questions? In that case, then, we move on to the final item, and I'm afraid it's you again, Alison.
Yeah, sorry about that. So final paper is an update on behalf of Robin Gears, Director of Public Health, in relation to the Outbreak Engagement Board and Health Protection Board. Very briefly to note, I think we've reported at previous health and wellbeing boards for a little while that there's been no meeting of the Outbreak Engagement Board, which had been paused for a little while. But that was pulled back together in December of last year to meet again, specifically to discuss the local outbreak management plan, which was updated and to request the approval of the Outbreak Engagement Board for that. Brief update in terms of COVID vaccination uptake and update from key partners. So, as mentioned, the primary agenda item was in relation to the outbreak management plan, which unsurprisingly required updating in the changes that have taken place in relation to context of COVID and how we're responding to COVID. And those key changes are listed there in 4.3, and then the plan aims in 4.4, which the aims of the plan haven't significantly changed, just kind of the response has. So just for the information of the Health and Wellbeing Board, the Outbreak Engagement Board did approve that plan so that if it hasn't already, will be kind of published on the council's website. Yeah.
Thank you, Alison. Any questions? In that case, we can finish early. Your next delight will be on the 16th of March here. Thank you. And I didn't say earlier, but Happy New Year, everybody.